All right, everyone, welcome back. Day 5, foot, ankle, lower leg injuries. The boys have finished up their trampoline dunk ball outside without injury, so that's always a plus. I will admit I might have taken part in the trampoline dunk ball as well, and I hit my elbow on the rim, which is not a sentence I've ever said before in my whole life. Now, in full transparency, the rim was not at the full regulation 10-foot height, but its actual height will forever remain a mystery. We're going to get back into injuries today. We're going to stay almost entirely in the lower leg, where some of our other ones have focused more on the foot and ankle. Today is going to be focused primarily on the lower leg. We're going to start off with the most common lower leg issue that I see, which is shin splints, especially this time of year under normal circumstances. I'd have about 1.5 million track athletes coming into my office complaining of their shins hurting. Wasn't so much of an issue this year because it was nice weather. The track team was able to get outside a little bit earlier. But last year, I dealt with a boatload of shin splints because the weather was terrible, a lot of ice, even late into the year. And the track team spent a lot of time running inside. And that floor is very durable, but it's also very, very hard. And it did a number on their shins. So shin splints, I'm sorry to break the news to you. There's no actual medical injury called shin splints. It's kind of a catch-all term that we use to categorize 6 or 7 different actual injuries. The most common 2 that I see are medial tibial stress syndrome and posterior tibialis tendonitis. Now, those are 2 very different things. While they're not very geographically far apart, maybe a half an inch or so, one involves the bone and one involves the muscle, and I'll break that down for you as we go. But medial tibial stress syndrome, the shin bone, just like any other bone in the body, is going to adapt to the stresses that you put on it. And if you're like me over the winter, you don't put a lot of stress on your bones as you sit around Thanksgiving and Christmas getting fat. So we come out for track season, and all of a sudden we're running, and our bones aren't used to it, and they get inflamed. They get angry because we ramp it up way too fast, right? You didn't do all the workouts your track coaches sent out for preseason. Instead of that nice gradual ramp up that we should have, they didn't do anything, and then bam, we ramp it up too fast, and the bone gets super angry. That's primarily the cause that I see. It can also be caused by flat feet, combined with poor fitting shoes, poor arch support. I'm a big proponent of going to a professional, whether it's the running wheel store or wherever, and we all have different types of feet. Flat feet, high arches, we pronate, we supinate, we land heel, we land midfoot. Go get a shoe that's designed for your foot type and your foot strike. That'll greatly reduce the chances of you getting injured. All right, so what can happen with this shin splint, especially, I would say probably 2/3 to 3/4 of the cases of shin splints, this MTSS, that I see have flat feet. So that arch of the foot, that spring mechanism, acts as a shock absorber. And when those feet flatten out, you've lost that primary shock absorber. You pronate, your feet turn in. You almost evert just a little bit. The foot turns in, puts a lot of stress up the medial border of both shin bones. So we talked about the tibia, the tough tibia, the one that's on the inside. You can take your thumb just under the belly of your calf and find that inside border of the shin bone and go all the way down to the ankle bone. I primarily see MTSS in the distal half, distal third, that farthest away part of the tibia. And like I've said multiple times before, that may be where the pain is at, but that may not be the root cause. So it's going to be very important for you, if you're the medical person, to do a full eval, both in a weight-bearing position and a non-weight-bearing position. See how much their arch falls. You can measure that. Watch them walk, both in shoes and barefoot. Watch them run. We need to do a basic biomechanical analysis of them as well to get a complete understanding of what we're dealing with and what might be our root cause. MTSS is important because if not treated properly, it can lead to stress fractures in the future. Here's a decent picture that shows you some of the zones that I typically see. The blue zone here is where I typically see this medial tibial stress syndrome. Again, that inside part of the tibia, the distal half, distal third. From a taping and compression standpoint, for the most part, I don't think shin splint taping is very effective. I think it treats the head more than it treats the shin. The one exception might that be if you've got somebody that's got flat feet, and that's what's causing their shin splints, their MTSS, then yes, a tape job of their arch, some arch support, some compression in that area to help rebuild their arch is going to help their shin pain. If their root cause is flat feet and you tape their shin or you wear a compression sock, that's not going to fix the problem. They'll feel it. They may get some prophylactic experience there, but you're not addressing the root cause. Some of the more common treatments for shin splints, again, this kind of depends on what the root cause is. If it's just an overuse, they've ramped up too quickly, we might need to limit them, decrease their activity to more appropriate levels. If it is a flat foot issue, then some taping, orthotics, things like that. A lot of times with that posterior tibialis tendon, and I'll show you a picture of what that looks like here. This is the inside bone of the foot. You see this posterior tibialis tendon comes right down the inside border of that, behind that ankle bone, and down. If the calf is tight, or some of the surrounding structures are not strong enough, or that foot is a little flat, then this muscle tries to compensate. This muscle tries to compensate and hold that arch up, and it can get really inflamed and really angry right in here. Excuse me. The cup works better if the lid is open. So, this muscle can get angry and be very, very painful. Now, geographically, that's not very far, a quarter of an inch, half an inch from the medial border of that shin bone. So you need to evaluate, is there pain right on the medial border or just off of it? There's also some muscle testing you can do to help determine that as well. I'm not real big into anti-inflammatories. Maybe take it for a day or so, the ibuprofen and whatnot, but do not take it long term. You need to evaluate their calf flexibility and then get them started on a strengthening program, kind of an all-encompassing strengthening program, but focusing on that posterior tibialis down and in. And then work on balance. I think balance is one of the more underutilized parts of the rehab program. Stress fracture, this is what can happen if the MTSS is left untreated or the athlete continues to participate. They may get this stress fracture. One of the distinguishing factors between MTSS and a stress fracture, that shin splints, is typically with the shin splints, that MTSS, they'll have just general diffuse pain, the bottom third of that shin bone. If you're palpating them and they're like, yeah, that's tender, and then there's one spot that is holy cow tender, way more significantly tender, that quote unquote hot spot, then we may be looking at a stress fracture. Okay? Stress fractures can sometimes feel better in the morning because we've obviously been non-weight bearing, or sometimes shin splints can hurt in the morning. All right, compartment syndrome. Compartment syndrome, when I'm looking at lower leg contusions, this is what I'm always trying to prevent in the back of my mind. The majority of compartment syndrome cases are what we call acute traumatic. So you've been kicked in the shin that just missed your shin guard, or you got stepped on, or you were in a car accident and your shin went into the dashboard. Most of them are acute traumatic. Occasionally, like the marathon runners, can get what we call exertional compartment syndrome, where in mile 15 or so, they start having shin pain. But I talked earlier yesterday about distal loss of sensation. Compartment syndrome is swelling that cuts off the nerve supply to the rest of the lower, or not cuts off, but dramatically reduces the nerve supply and blood flow to the lower leg. So if you get kicked in the thigh, you've got the big femur right in the middle and muscles that surround the whole thing, right? It's got plenty of room to swell, right? The lower leg does not have room to swell. You essentially have the shin bone, the tibia, and the fibula on each side, and everything kind of runs down the middle of the pipe. And swelling cannot expand, right? Because the bones are creating this barrier. So the swelling goes internal. And when it does that, it puts pressure in there and reduces or cuts off blood flow and nerve supply. So as I'm evaluating somebody for a lower leg contusion, I'm always trying to rule out compartment syndrome. Make sure they have good nerve supply and blood flow. You can check what's called capillary refill. You squeeze their toenail, and it should go white, and then the blood flow should come right back. If that's not the same as the other leg, or their foot is cold, or they've got numbness and tingling, then we could be concerned about compartment syndrome. You can see here, this is a cross section of someone's left leg. So if you were to go about mid thigh and cut your thigh, mid lower leg, just about mid calf, horizontally cut your leg, and then look down the rest of your lower leg. This is what you'd see. This is somebody's left leg. So we got the tibia here, the fibula here. See all these different compartments. All right, our lower leg is split into compartments that are held together by really tough pieces of fascia. You got the anterior compartment, the posterior compartment, the deep posterior compartment. You got all these compartments, and with each part of this, and I'm not going to make you learn what nerves and what blood flow, but you can see what nerve supply and what arteries and veins run through each compartment, right? So if you got hit in the front or in the back, it would cause numbness and tingling in different areas, right? So this is really good for me to know as the medical person to try to figure out what compartment we might be dealing with. One of the reasons that compartment syndrome is so serious, but like any other part of the body, if it goes for too long without nerve supply or blood flow, the tissue will die. And anytime amputation is a possible outcome, I will take this very, very seriously. One of the home instructions that I give my athletes that have compartment syndrome is if at any time during the night or before I see you again, your leg starts going numb, you need to go to the emergency room. Don't wait till tomorrow. Don't go see your doctor tomorrow. Don't come see me tomorrow. Go to the emergency room. Because if that foot goes too long without blood flow, it will die. And then you're going to be like Lieutenant Dan and need a new leg. This picture does a really good job of showing the individual arteries and nerves here, as well as all of the muscles, right? So here's the calf muscle, the soleus muscle, we got the anterior tibialis here, all of these muscles. This is what the cross section looks like of our lower leg. Again, that compartment syndrome, possible neurological impairment. I have them move their foot up and down. I compare strength side to side. Sometimes they'll have what we call drop foot. So as they walk, their heel will kind of hit and then their foot will just slap. They can't control it and toe off. That drop foot, the nerve that controls the anterior tibialis is damaged. So that muscle's not working and they just slap the ground. They got that drop foot. That's going to finish up day 5. Tomorrow we will get into fractures. Don't eat breakfast before you watch tomorrow. Thank you.